Now, moving on in the brachial plexus injury. In this section, we'll be going through the obstetric brachial plexus injury. What if this happens in a neonate or a child who's just born? In this section, we'll be going through the classification and the clinical features of Erb's and Klunke's palsy, how to manage it, and what are the different operative options we have available for Erb's and Klunke's palsy. So, what is obstetric brachial plexus palsy? Obstetric brachial plexus palsy is caused by excessive traction on the brachial plexus during childhood. Example, by pulling the baby's head away from the shoulder or exerting a traction with baby's arm in abduction. Usually, this is called as shoulder dystocia or dystocia. And in what happens is sometimes in from breech delivery, or if the baby's position is in abnormal lie, then this usually happens is that excessive traction, if done on the baby's neck, this can pull the neck in one direction with the shoulder going in another direction. Or for example, as you can see, the shoulder is being pressed by the symphysis pubis of the mother and neck is being pulled in another direction. This can lead to brachial plexus injury of this side. Patterns of injuries include, there could be upper root injury, that is C5, C6, C7, that is called as Erb's palsy because they occur at the Erb's point. Then the lower nerve root may be involved in form of C8, T1 called as lower root injury or Klunke's palsy, or the whole of the brachial plexus may be involved. Then there is Naraka's classification based on the types of injuries how it can be classified. There's actually 4 grades of classification. Group 1 includes C5, C6 injury or upper nerve lesions of the brachial plexus. Group 2 is C5, C6, C7 involvement, it is upper in the middle part. Group 3 includes the entire plexus is involved, that is also the upper, middle and the lower, that is C8, T1 are also involved. And group 4 is entire plexus associated with the Horner syndrome as well. There are actually parasympathetic signs which are also coming along with the involvement of entire brachial plexus. Isolated injury to TC8, T1 is although very rare, but yes, it can occur. Although it's very rare, because if avulsion at C8T1 is occurring, that means the injury mechanism is such that it's going to affect the whole of the brachial plexus. Coming to the clinical features. If it's Erb's palsy, that is the C5, C6 is involved, then usually it is related to C5, C6, C7 injury. Shoulder muscles are mainly affected. Supinators are paralyzed, that the arm is usually, if you see, this is called as Vater's tip deformity. That is that the arm is lying sideways because it cannot be abducted because supraspinatus are paralyzed, therefore the arm and shoulder is adducted. Forearm is elbow is extended because the bicep is paralyzed and elbow cannot be flexed. And as this whole the supinators are paralyzed to the forearm, therefore the arm is in pronated and this flexed position, as if the patient is asking for the tip from you. This is a classical presentation in case of Erb's palsy. If it is lower roots are involved, that is C8T1, this usually leads to injury of C8T1 elbow, as the bicep is not paralyzed, so it can be flexed. But mainly the C8T1 leads to loss of intrinsic muscle and lumbricals of the hand. This leads to classical ulnar nerve palsy, which is called as Klunke's palsy, or this is called as claw hand, in which this usually this claw hand can also be seen with the lower nerve roots of the injury, when especially with the high ulnar nerve palsy as well. This may or may not be associated with unilateral Horner syndrome. Other is total plexus injury, which may be associated with the Horner syndrome or may not be associated with the Horner syndrome. Usually all the muscles, whether up from the shoulder till the hand, are all paralyzed. There is a flail arm, finger muscle paralysis, there is a vasomotor impairment as well, and usually it is associated with unilateral Horner syndrome, that is ptosis, anhidrosis and meiosis of the one side of the eye. It's coming to the further subdivisions, as in Naraka's classification is there. This is usually group 1 was C5, C6 injury, in which the shoulder muscle and supinators are paralysis, arm and side and pronated, elbow is extended. In Naraka's type 2, it was actually C5, C6, C7 injury, where the extensor actually get paralyzed. There's a clenched fist, weak or absent tricep function, because the C7 is involved, therefore the elbow extension, wrist extension and finger flexion affected. Coming to type 3, which is actually whole of the brachial plexus without the Horner syndrome, this leads to flaccid paralysis of the arm and almost all the muscles are affected. In type 4, it was the complete paralysis with Horner syndrome, in which there is flaccid paralysis and the Horner sign symptoms are present, that is the anhydrosis, meiosis, and ptosis, along with the C8T1 involvement. Coming to the management, depending upon management, again start where is the lesion, what is the type of the lesion, and then we have to proceed accordingly. Usually in 60 to 70% of cases, there is neuropraxia which recovers spontaneously, and there is always a return of bicep activity by end of third month. But if paralysis may prove partially, that is partial paralysis still present, then may need to intervene surgically. And if the paralysis remains, then we may need to, and within 3 months to 6 months time, we need to decide whether the whole of the plexus is involved, upper limb is involved or not. Then depending upon what is the type of the lesion, we have to move towards nerve grafting or nerve transfers. Usually operative treatment, it could be simply excision of the scar, that if the nerve is getting caught in the scar, this could be there. Using a sural nerve grafts can be used. There could be a release of subscapularis in case of Erb's palsy, because it's gonna then the other muscles which are actively working, which can actually extend rotator. Then other options could be tendon transfer, that is after the 6 months. Pec major and other muscles, the lat dorsi, can be used for different group of muscles which may be paralyzed. Then there is rotation osteotomy. The humerus may be needed because subscapular is keeping the shoulder in internal rotation. Therefore, an external rotating osteotomy may be required as well. Other options include splitting a serial casting, which may be needed in case to keep the joints supple, and physiotherapy may be initiated initially before we have to proceed surgically. In this section, we have briefly gone to the two very important diseases with the brachial plexus injury in the children or in the neonates. That is usually the childbirth trauma, which can result in Erb's palsy or Klumpke's palsy. Erb's palsy is usually at C5, C6, C7 palsy, and loss of those muscles which get paralyzed, which are moving the shoulder and the elbow. This results in internal rotation, adduction of the shoulder, extension of the elbow, with pronation of the forearm. But if it's a Klumpke's palsy, this usually involves C8T1 injury, which is the lower half of the brachial plexus, and this leads to classical deformation called as claw hand presentation in children. Keep watching sqadia.com. Thank you very much.